I'm going to be presenting on the Premia TOPS device. This is the FDA IDE trial that was done in the United States, so I'm presenting on multiple authors and multiple sites. I have no relevant disclosures with regards to this presentation. So the TOPS device, just in case you're not familiar, this is a total posterior spine system is what it stands for. This is considered a facet arthroplasty device. Its indications include patients with up to grade 1 spondylolisthesis, who have moderate to severe lumbar spinal stenosis with radiculopathy and low back pain. With regards to the FDA study that was done, they looked at, this was a multi-center trial, it was prospective and randomized. It was a 2-to-1 enrollment, so with 2 times as many patients enrolled with the TOPS device, and it was compared to posterior interbody spinal fusion for a single level fusion with a TLIF interbody fusion. Patients undergoing the procedures for the fusion had either Medtronic or J&J instrumentation used. It was for single level pathology anywhere from L2 to L5 in the spine. The patients had to have severe degenerative spondylolisthesis but could not pass grade 1 with stenosis. You had to have at least a 40 baseline ODI. Patients were between 35 to 80 years of age and predominantly leg compared to back pain as far as that was concerned. Patients with BMIs greater than 40, more than one level involved, and loss of more than, or having less than 4 millimeters of residual disc height were excluded, and anyone with greater than grade 1 spondylolisthesis. If you look at the baseline demographics, and just going back, there were 300 patients total, 305 enrolled. The study took a look at patients, and the plan was to try and get to 500 patients, but looking at 300, 400, and 500, and once statistical significance was reached, the trial was stopped, so it was stopped subsequently at 305 patients. If you look at the baseline demographics, the patients across the board were similar in age, BMIs, height, weight, smoking status, and if you look, the majority of the patients had the procedure performed at L4 or 5, including both for the TOPS as well as for fusion. If we look at the operative characteristics, there were really no differences between the TOPS device and fusions. For the primary outcome, so we looked at what was considered the composite clinical score. So this was looking at 6 different components. 1, the patients didn't have a reoperation. 2, the patients didn't have a lumbar injection performed after the initial procedure. They had to have an ODI reduction greater than 15 points, no new worsening or worsening deficits, no major device-related adverse events, and then finally, looking at fusion status for the TOPS device, that would be continued motion, and for fusion patients, that would be an actual fusion. In order to achieve the primary outcome, you had to have all 6 of these. So you had to meet all 6 of these criteria to be considered a success. And if you look at that primary outcome, the TOPS was actually found to be superior to fusion as far as the status was concerned. And even when you exclude just the fusion status, that did improve the results for the fusion patients, but still you saw a superior result for the TOPS device. If we look at subsequent surgical interventions, overall there was less subsequent surgical interventions for the TOPS device, especially compared to some of the fusion patients. And probably one that's of interest, pedicle screw loosening. Only a total of 2 subjects returned to the operating room specifically for pedicle screw loosening. The study was carried out to 3 years, and so we also have some of the 3-year results, not the CCS, but looking at just some of the baseline characteristics. And if we look at the percent of patients that achieved MCID at 3 years out, and this includes an ODI score of greater than 15 points improvement or greater than 20 points improvement in low back pain and leg pain, we still saw significant or at least better results with the TOPS device in all of these categories. And then finally, it's important to look at the continued motion, as this device is considered a facet arthroplasty. And so if we look at continued motion with the TOPS device, you saw that there was continued motion and flexion extension as well as lateral bending in patients at all time points. So we saw continued motion throughout. So in summary, the FDA trial actually resulted in significant superiority at 24 months with continued improved outcomes at 3 years. It demonstrated significant improvement in ODI, VAS back pain, VAS leg pain, compared to posterior interbody fusion with the TLIF. Reoperations were lower compared to the posterior interbody fusion, and it is a motion-preserving implant that allows for surgical decompression in patients with low-grade spondylolisthesis. Thank you.
question for the last speaker. I was really intrigued by your results, and I was wondering, do you have any a clue on what percentage of the patients had these lysis?
Yeah, so when we looked at it, I think specifically you're talking about lysis in the pedal screws or loosening of the pedal.
No, the isthmic spondylolisthesis.
Oh, isthmic. No isthmic spondylolistheses were included. So it was all degenerative, no patients with an isthmic spine.
Okay, and then another question, why did you choose for smoking as a confounder to exclude that you said never smoking? Did you also try it to evaluate it with the patients that had stopped smoking a few months before?
So the smoking status was something that was reported.
Yeah.
In general, we were not looking to try and distinguish between smoking and not smoking. In that case, there were also some patients that were smoking in the fusion arm of the study as well. But I do think that that's something of interest, especially a patient that may not quit smoking that would be a difficult fusion candidate. This may be of some benefit.
Okay, well, thank you for sharing your results.
Please, some other questions?
Questions? A question from the third paper. How do you know that the pain is from the facet joints? Can you comment on that?
Yes, it's not actually that we're not treating pain in the facet joints. If you look at it, was actually patients primarily with leg pains. We're treating radicular pain and or stenotic associated pain, so neurogenic claudication. So what the device allows is you can do complete facetectomies with the decompression and then with placement of the device, maintain motion without doing fusion. If you wanted to use it also for facet-mediated pain, then you're doing a complete facetectomy, so theoretically that will also reduce facet-mediated pain.
Okay, so what you're actually doing is extended decompression.
Correct. This is like doing an extended decompression, but without needing to do a fusion.
Maybe to follow up on for questions here before we go to the floor again. So would you plan now to also compare TOPS versus decompression alone? Because as I said before, many patients now would only potentially receive a decompression alone. Maybe in the States it's still a little different, but here in Europe at least.
Yeah, I think the problem is also an FDA study, and so for the FDA study, you've got to compare it to a fusion. So that's in order to do an IDE trial and look at the device itself, you're going to have to compare it to a fusion versus a decompression. I think it's worth looking at it compared to a decompression. Depending on some of the papers that you look at, there may be up to maybe a 10%, maybe 12-15% rate of return to the OR within 2 years for a decompression alone. So if these decompression results, or if these return to the OR results are correct, then this actually may be better in some cases than a decompression alone as well.
Perfect. I think you have to close up, please.
Yes.
Yeah, so there's longer term data that's come out of Europe and other places. This is just from the FDA study, so it's up to 3 years data. Long-term failure still looks good on the device if you look at some of the other studies and things that have been presented in the literature. But that's always going to be the concern with any arthroplasty. So.
Thank you so much. I think we have to close. Thanks for the speakers.
Thank you.